Hello, everyone. My name is Shadi Yaghi. I'm a vascular neurologist at Brown University, and I'm the writing group chair of the scientific statement, Treatment and Outcome of Cervical Artery Dissection in Adults. Vertebral artery dissection, it accounts for 2% of ischemic strokes, but up to 25% of strokes in young adults. Dissection happens because of interplay between certain genetic factors like connective tissue abnormalities, environmental factors or triggers such as infection or neck trauma, and risk factors such as low body mass index. The diagnosis of cervical artery dissection can be very challenging. These patients could have isolated neck pain or headache and sometimes non-specific symptoms. So it's really important to consider a diagnosis of cervical artery dissection in patients who have new or worsening headache, particularly in the presence of cervical injury or manipulation, or sometimes they could have a Horner's syndrome if they have a carotid dissection. The diagnosis can be made based on a CT angiography or an MR angiography, or in rare occasions, a cerebral angiography. Certain imaging signs of cervical artery dissection, and we show these in figure 1 in the paper, they include a tapering stenosis or occlusion at a typical dissection site. So typical dissection sites are the V2 or V3 segments of the vertebral artery, or 2 to 3 centimeters above the bifurcation of the carotid artery. So, a tapering stenosis or occlusion is one of the imaging signs of cervical artery dissection. Intramural hematoma is another one. Bleeding in the vessel wall that you can see on MR angiography. Generally, this is a hyperintense signal on fat suppressed T1 double lumen as well. You can see two lumens, the false lumen and the true lumen. You can sometimes see an intimal flap, and sometimes you can see a pseudoaneurysm. Certain imaging artifacts can mimic cervical artery dissection and a pseudoocclusion. If there's an intracranial occlusion, you can see a flame-shaped or tapering occlusion that's suggestive of more of a distal occlusion. So just when you're considering the diagnosis based on this, make sure that there's no intracranial occlusion before considering a carotid dissection diagnosis. In addition, when seeing patients with cervical artery dissection, it's important to think of underlying connective tissue disorders that could be associated with the dissection, monogenetic connective tissue disorders, particularly in patients who have clinical features or family history of these conditions. And in these patients, we could consider genetic counseling and genetic testing. In addition, certain associated conditions that could imply an underlying vasculopathy include aortic root dilatation and cerebral aneurysms. So, screening for these conditions could be considered. The diagnostic workup in patients with cervical artery dissection is shown in figure 2 in the manuscript. Please refer to it for more information about this.